Here we propose a novel algorithm for management of congenital hereditary endothelial dystrophy (CHED). I give credit to Dr. NEET MEHTA, Dr. Muralidhar Ramappa, Dr. Sunita Chaurasia, and Dr. Deepak Paul Edward for their contributions. I have no financial interest. Proper consent has been taken for all the clinical photographs used in this video. The incidence of congenital corneal opacity, including congenital glaucoma, is 6 per 1 lakh newborn, out of which CHED makes up a small minority. Although the incidence of CHED is quite low, it is more common in places with a higher consanguinity. In a recent study published by Ramappa et al. On outcomes of DSEC in pediatric age group, demonstrated that nearly 69.5% of all the operated cases were of CHED. Managing cases of CHED involves taking a lot of challenging decisions. This is because of a lack of definitive conservative approach and a dilemma in deciding when to operate. Currently, the definitive management include various forms of corneal transplantations, including penetrating keratoplasty (PK), Descemet's stripping automated endothelial keratoplasty (DSEC), and Descemet's membrane endothelial keratoplasty (DMEK). All these have various limitations considering the longevity of the child, shortage of donor corneas, complex surgical procedures, chances of graft failure, and the reluctance of parents to get their child operated at such an early age. Penetrating keratoplasty was the standard of treatment for children with CHED. Still, the decision to proceed with PK is complex, especially when operating in a child. It being an open-to-sky procedure leads to chamber shallowing and chances of expulsion of contents. A rapid and severe post-operative inflammation in children can lead to higher chances of graft rejection, peripheral anterior synechia formation, glaucoma, and even cataract development. A robust wound healing process leads to corneal neovascularization, early loosening of sutures, overriding of the graft, and a definite risk of traumatic wound rupture. In spite of all of these, penetrating keratoplasty offers a pristine clear corneal graft. DSEC, on the other hand, is currently one of the treatment of choice in cases of CHED. Its closed system technique leads to lesser intraoperative complications and a faster visual rehabilitation. It has less suture and suture-related complications and a preserved structural integrity of the globe. However, unlike penetrating keratoplasty, it has its limitation in attaining a pristine clear graft and is technically more challenging. Even though keratoplasty is the mainstay of treatment for patients with CHED, amblyopia management and genetic counseling are crucial in visual rehabilitation of children. Amblyopia management should be as aggressive as possible, with prompt refractive correction and patching therapy directed under the guidance of a pediatric ophthalmologist. Without successful treatment of amblyopia, the visual outcome is poor despite a clear medium. It is also necessary for genetic counseling of the patient and the parent, and to explain the risk of having a sibling with CHED is 25%. We know that CHED is due to a mutation in the SLC4A11 gene, leading to a dysfunctional BTR1 membrane protein which is unable to express itself on the cell surface. Agents like non-steroidal anti-inflammatory eye drops have shown to rescue these endoplasmic reticulum retained mutants in cases of CHED and can have a potential role as a conservative modality. Another possible role could be of the anti-glaucoma agents that decrease the intraocular pressure and thus the imbibition pressure. Gene editing using CRISPR-Cas9 can be a future modality in management of CHED. Here we propose a management algorithm for CHED aiming to streamline the management in terms of deciding between the conservative approach versus surgical intervention and how to appropriately time for corneal transplantation in these cases. We divide CHED into mild, moderate, and severe groups based on the anterior segment visibility and anterior segment optical coherence tomography features. Mild cases include those where anterior segment details, that is the iris details and the pupillary margin, are clearly discernible through the cloudy cornea with no secondary changes seen on the AIOC2023. Moderate cases include cases where anterior segment details are obscured but the pupillary silhouette can be seen, with no significant secondary changes on the OCT. Severe cases include severe corneal clouding that obscures the anterior segment view and ASOCT showing significant anterior stromal, that is Bowman's level scarring, and posterior stromal or Descemet's level scarring. Thus, we divide CHED into these three groups. Apart from these, corneal haze in CHED can also be graded objectively using the corneal densitometry, as seen in this unpublished data from a study being conducted at LV Prasad Eye Institute, where CHED has been classified into mild, moderate, and severe groups based on the densitometry values. Mild cases can be managed by a conservative approach. It is important to correct amblyopia with appropriate patching exercise, provide optical correction. In mild cases, there can be the role of using topical NSAIDs or drugs that control the intraocular pressure by mechanisms explained earlier. Moderate cases can benefit from undergoing DSEC and can be planned as early as possible in order to avoid development of amblyopia and secondary corneal changes. Severe cases can benefit with either a superficial keratectomy followed by a DSEC, and in cases with extensive involvement of all the layers of the cornea, will benefit better from undergoing a penetrating keratoplasty. In cases undergoing a PK, one needs to assess the benefit and risk ratio, the adherence of the parents for a diligent post-operative care, and regular follow-up in deciding the time for the intervention. With this, we propose this algorithm for management, which is based on the severity of the corneal haze for streamlining the approach to cases of congenital hereditary endothelial dystrophy. Thank you.